This is Namitha Seth Mota for NEJM Catalyst. Today, I am speaking with Dr. Selwyn Rogers, a trauma surgeon, public health leader, and health equity expert. Dr. Rogers is the Dr. James E. Bauman Jr. Professor of Surgery, Chief of Trauma and Acute Care Surgery, Founding Director of the Trauma Center, and Executive Vice President for Community Health Engagement at the University of Chicago Medicine Pritzker School of Medicine. Selwyn has spent his career caring for patients affected by gun violence and building programs designed not only to treat trauma, but to prevent it. During the conversation today, we will draw on examples and themes from his latest book, Healing the Gun Violence Epidemic. We will discuss why gun violence is an issue that health system leaders need to care about and what strategies and tactics they can effectively implement to improve prevention in their own communities. Selwyn, thank you for speaking with NEJM Catalyst today.
Thank you, Dr. Mata. How are you today?
I'm good. Thanks for being here. And we are looking forward to the conversation. And let me start with you and your experience. You have spent your career caring for victims of gun violence as a trauma surgeon. Tell me, was there a particular experience or set of experiences that changed the way that you thought about gun violence and transitioned from not only as an injury that needed to be operated on, but actually as a public health crisis?
Well, that's a great question, Namita. One of the things that has always struck me is that we often think of gun violence as an event, as an isolated occurrence. But from my public health training, I was always concerned about the issue of re-injury or recidivism, where people who are at high risk have recurrent episodes of gun violence. And in that context, it is not a single event, but something that has risk factors, no different than cardiovascular disease or stroke, and protective factors that can help prevent injury in the first place. And I've been pretty informed over the 3 decades as a trauma surgeon how often the circumstances of a victim of gun violence is driven by their geography, i.e., where they live, just as much as it is by personal factors.
What are some of the other risk factors that you have identified based on your research and experience? And just as importantly, what are some of those protective factors?
Well, sadly, the same issues that drive poor health outcomes and affect individuals with respect to healthcare disparities in urban settings that are the social drivers of poor health, be that education disparities, access issues, housing insecurity, income inequality, poverty, and racism. Those are all factors that also coexist in patients who are at the highest risk of gun violence, often driven by the neighborhoods in which they live, as much as their individual behavior that's also driven by the circumstances in which they live. And those are the exact same factors that lead to poor health in so many of our cities in America. In terms of protective factors, I mean, the same things that protect us, be that higher level of income, lack and access to mental health services, are the same things that protect us from, unfortunately, being the victim of self-inflicted gun violence or violence turned outwards, which is in the case of intentional gun violence.
These seem like factors that are often out of control of care delivery systems that actually provide the care once patients come in as victims of gun violence. You've advocated that health system leaders, which are most of our readers today listening at NEJM Catalyst, need to think differently. Given that these macro factors are in fact so macro, what is the most important mind shift that healthcare leaders need to make? And quite frankly, why is it our problem and not a larger policy or societal one to tackle?
That's a great question, Namita. It's not either or, it's
Mm,
and largely because we as health systems are often part of communities, and the communities in which we serve are the communities that are affected by firearm related injuries. I need to make a distinction between the fact that we often think that gun violence is an other problem, that is a them or they problem and not a us and we problem, because from the 2-year-old child who's accidentally shot in their head by a young sibling because of inadequate gun storage, that we should be advising our pediatrician colleagues around safe storage of guns in people's homes who do own guns, to the elderly grandfather who's despondent about the loss of their spouse after 50 years of marriage and owns a gun and is depressed and is at risk for suicide, to community violence. All of those things end up in our health systems and our trauma bays and our clinics,
mm,
and affect every care provider in our health systems. And given the dramatic nature of firearm related injuries, we often miss the secondary effects on the staff and the physicians and nurses, and ignore that component that is a secondary trauma to all of our providers. So that's why I argue that this is a problem that health systems need to turn towards to effect policies and programs to mitigate the impact of firearm related injuries in their health systems and the communities that they serve.
what does that look like in daily operations? So let's say a hospital or a trauma center takes responsibility around decreasing the incidence of some of those firearm related injuries or the sort of scenarios that you outlined. What does that look like? What do they do in daily operations to live up to that responsibility?
So there are a couple things that are possible that health systems and hospitals can invest in. I will start with um, a series that are much more within controls of health systems, and that is namely development of hospital-based violence intervention programs, of which there are probably on the order of 80 or so across the country now, and expanding. The Health Alliance for Violence Intervention, a nonprofit organization that helps to train hospitals in the development of health interventions to prevent violence, is very helpful for giving guidance and consultation for development of these types of programs. At the University of Chicago Medicine, where I work, since the inception of our hospital-based violence intervention program, in concurrence with our adult trauma program, we have cared for over 8,000 patients who have been victims of gun violence, who are gun violence survivors, to do two things: provide psychological safety of the patients and their close contacts, but also to connect them with services in the community that they may not be aware of. And those services can be very helpful in the healing process, as people 95% of the time after a firearm related injuries survive, but you're left with what happens next. We focus
Mm,
on the incident as an event, but there is a before the event and an after the event. And oftentimes the after event is what needs a lot of support in terms of mental, behavioral health, psychological support for survivors and their families.
Can you get a little bit more specific about these community-based partnerships and the type of impact that they are having? And related to that, given your experience in Chicago, what have made some of these partnerships with your center successful? And what have been some of the biggest challenges?
I will name three, and in naming three, I will be able to both share the successes and the challenges. So, a program that I was first involved with when I got to Chicago was led by Heartland Alliance, a nonprofit that is focused on ending poverty. And they tested and evaluated a program called the READY program, READI, which stands for Readiness and Development Initiative, to provide victims of gun violence economic development and cognitive behavioral therapy in order to assist them with post-traumatic stress disorder, anxiety, depression, as well as job training in order for them to enter the legal economy instead of the illegal economy, which some of them were involved with. And that was very restorative. And the University of Chicago's crime lab evaluated the impact of that program and found that it led to less recidivism or re-injury by gun violence. Two other programs that I sit on the boards of in the city of Chicago, the Institute for Nonviolence Chicago is a street outreach program that takes individuals who have been justice involved in the past, who are well known in the community, and provides them with training, and they help with secondary prevention or interruption, where they try to interrupt the cycle of violence and prevent retaliatory violence. That is, a shooting happens in a group or a clique, and the rival group or clique attempts to retaliate against that initial shooting. And these street outreach workers try to intervene and mediate conflict and create a truce to prevent retaliatory violence. So that's one set of interruptions. Obviously, when someone's injured, they end up in our trauma centers. And the third institution or nonprofit that I serve on the board of is Chicago CRED, which is led by former Secretary of Education Arne Duncan. CRED, C-R-E-D, stands for Creating Real Economic Destiny. And that organization as well takes victims of gun violence and provides cognitive behavioral therapy, job training, and job placement for up to 18 months in order to provide victims of gun violence a reasonable pathway forward for their economic improvement and sustainability. Those are all success stories, and we call that our civilian architecture or community violence intervention ecosystem and network of street outreach, community violence prevention programs, community violence intervention programs that really, through our web, tries to cover the city and take the highest risk individuals and provide them opportunities and cognitive behavioral therapy to prevent recurrent violence. The challenge, though, is the the organization that I alluded to initially, ran out of funding and is no longer functional. So here is a evidence-based program that has shown benefit that no longer exists because of funding. What gives me incredible hope, though, is the city of Chicago and the business community has invested over $100 million over the past 5 years to provide more of these services across the city in order to try to make a positive impact upon public safety and gun violence injuries in the city of Chicago.
As I am listening to you and wearing the hat of an NEJM Catalyst reader, I am thinking, yes, this all sounds amazing. And if I am the CEO or the CFO of a health system, I have competing priorities, I have limited resources. How do I justify investing dollars in gun violence prevention, decreasing recidivism? Uh, how do I think about an ROI for me at an organizational level?
It's a great question, and one of the challenges is how it's related to how do we pay for events that don't happen, which ties in with the
Hmm.
payment structures in healthcare. We don't get paid a lot for preventing things from happening. We get paid for doing things to people after things have happened. But I will posit to a health system, a community, a city, that at some level we all pay the costs of firearm related injuries, both economically as well as lost human potential. One of
Mm,
the challenges that happens is when a bullet traverses or bullets traverse people's body, it doesn't just affect that person, it affects everyone in their circle. And unfortunately, in the city of Chicago and throughout the United States in 2020, firearm related injuries surpassed motor vehicle collisions as the reason that a 1 to 19-year-old child is killed in this country. And so every time a 16-year-old child is killed on the way to school or after school, that entire class, that entire school is negatively affected. We also don't really calculate the cost of fear. That is, every time there's a shell casing found on a school floor, the school goes on lockdown. We now practice drills for kids to shelter in place. All those things have costs to them that are hard to calculate. But for healthcare providers and New England Journal of Medicine Catalyst readers, I don't think that health systems or hospitals or clinics can barricade themselves from the reality that gun violence can end up in their hallways as well, or their wards or the emergency departments. And sadly, we know across the country that these events have happened within our healthcare spaces.
hmm.
And what we don't often calculate is the psychological and mental health impact on providers as well. I know that every time we have, if you will, all deaths are bad, but when we have some of the horrific casualties where young people in particular are lives are cut short, our providers, nurses, residents, learners, attendings, sometimes break down and start crying at the senselessness of that lost life. And that has a cost as well. And the worst outcome that I've seen from my perspective as someone who truly enjoys the great saves, the things we do that, if you will, take people from the brink of death and they leave the hospital and you are really gratified with the work that the team did to restore someone back to health. But when I hear nurses and doctors and residents see horrific things from a firearm injury and say that that was so hurtful that I no longer want to practice nursing or medicine, I think we're losing
Mm,
some of the best and the brightest because of the impact that these losses are having on us as providers and as people.
yes, yes. As yes. uh, what would you want, if you had a magic wand, for health systems to start doing tomorrow? You mentioned earlier that training and encouraging safe storage practices, for example, would be one responsibility that health systems could undertake. What are some other tactical things that we could start doing in the short term?
You know, I'm going to actually give one that you wouldn't expect. I would encourage all healthcare system leaders and C-suite partners to leave their offices, leave the hospital, and spend time in community with community. There's so much that we can learn about what the real drivers are for people who just want to take care of the families and live safely and um, have good health for as long as possible. And I think there are times when we don't listen to the people that are most affected because sometimes they may be the best people to understand or share what they need the most. Obviously, no health system, no C-suite, no dean, executive vice president, community health agent can fix poverty, income inequality, racism, discrimination, but there are things that health systems can do as often the largest employer in the region, as an economic force that can be positive in community with community. So that's one. The second, I think, is all nonprofit health systems and for profits too are required to provide community benefits at some level. And I think being tactical about how those community benefit dollars are used and truly try to measure the impact of how those dollars are used can also be something that can be started tomorrow because in some ways they're being done already. And then the last bit, I write and read and lecture and write books around advocacy because I do think that there are things that we can advocate for on behalf of our patients. We have much more agency. I can call up my state senators or the representatives, and they will take my call in a way that an average citizen should be able to, but may not have access or agency to do. So I think that there are other ways that we as healthcare providers, as readers of the New England Journal Catalyst, as advocates for our patients, that we can do to make a difference in the lives of the patients that we serve.
There is clearly lots of work to be done, and we are optimists here at NEJM Catalyst. What is one thing that you are optimistic about as it relates to this next chapter related to gun violence and firearm related injuries?
So, Namita, I just turned 60 on May 29th.
Hey, happy birthday.
Yeah, I just turned 60. And I'm incredibly hopeful, not because I'm 60, but the last time the city of Chicago had less than 400 homicides in a year by gun violence was the year I was born, 1966. That gives me incredible hope that the set of things that we're doing in Chicago that could be replicated in other cities, um, public-private partnerships, economic development, investment in some of the more disinvested cities, community violence interventions, that the collective of those things in this ecosystem are working to take what 9 years ago was 762 homicides in the city of Chicago, the year I came to Chicago to launch the Adult Trauma Center at the University of Chicago. That's the number of homicides that happened in 2016. And as COVID occurred, it's hard to know exactly why this co-occurred, but the number of homicides in Chicago went up to almost 800 homicides. So to be almost half that in the past calendar year is tremendous. But to do that and be less than 400 and sustain that, or to go even lower than that, what would a single day Chicago look like if we were at 200 homicides or 100 homicides? As the city that my three kids were born in, that I grew up as a man, as a surgeon in Boston, you are physically at the Brigham and Women's Hospital at the moment. All three of my sons were born there. My understanding, the city of Chicago, Boston had less than 20 homicides this past year. So it's possible for cities to decrease the number, but they have to really work across health systems in a multi-sector way, with all in government, all in educational system, all in public safety, policing, working for that common goal. And I think it's possible, because at the end of the day, people working together can change the world, as Margaret Mead said. In fact, it's the only thing that ever has. So that provides me great hope.
Indeed, it does. Happy belated birthday. And thank you for joining us today.
Thank you so much.
Is race a medical fact or a flawed assumption? What happens when medicine gets race wrong? I'm Rachel Gottbaum, and this is Intention to Treat from the New England Journal of Medicine. Join us for Season 2, The Race Equation, where we examine assumptions about race that are harming patients. Listen and subscribe to Intention to Treat wherever you get your podcasts.